We are presenting our research evidence-based practice project on the risk of developing endocarditis in intravenous drug users and a policy that can be implemented to reduce incidence and prevalence overall. What is the association of intravenous drug use and infective endocarditis? One of the most challenging and costly complications of IV drug use is endocarditis. It is a rare, life-threatening bacterial valve infection that can destroy heart valves and spread throughout the body. With numerous needle punctures giving aggressive staph bacteria many opportunities to enter the blood through the broken skin, dirty drug paraphernalia increases the risk. Staphylococcus aureus is the most common etiologic organism in patients with IVDA, infective endocarditis. MRSA accounts for an increasing portion of Staph aureus infections and has been associated with previous hospitalizations, long-term addiction, and non-prescribed antibiotic drug use.
Our group searched multiple databases to find an answer to our PICO question. We began our research using the Rutgers University Camden Library database. In addition to the RUC library, the databases led us to articles published in multiple places, such as Science Direct, PubMed, EBSCOhost, and many others. Our search was then narrowed down to the publication type as well as the date range of the publication to ensure validity of both the time frame and information. The dates included in the search were limited from 2016 to present.
Science Direct is a website that provides access to a bibliographic database that contains both scientific and medical publications from the publisher Elsevier. The site contains over 18 million pieces of content and included are more than 4,000 academic journals, as well as over 30,000 ebooks. PubMed is a website that primarily accesses the Medline database of references and abstracts on life sciences and biomedical topics. The United States National Library of Medicine at the National Institute of Health maintain the database for information retrieval. EBSCOhost is a website that is a leading provider for research databases, e-journals, magazine subscriptions, ebooks, and discovery services for academic libraries. They provide libraries, healthcare and medical institutions, the government, and corporations with access to content and resources to serve the information and workflow needs of their users. NIH NLM stands for National Institute of Health, National Library of Medicine. It's operated by the United States government and is the world's largest medical library. When we conducted our search, we used keywords as well as inclusions and exclusions. So keywords again included words like endocarditis, drug consumption rooms, heart complications, safe injecting, endocarditis, etc. Our inclusions were limited to full text, journal articles, peer-reviewed journals, and clinical guidelines. Excluded were articles prior to 2016. We know that articles that were created in the last 5 years are more accurate than outdated ones. Based on our keywords, inclusions, and exclusions of this search criteria, 26,448 results were found. Of those 26,448 items, we chose 14 articles that pertain directly to our PICO question.
For the study selection screening, to choose the most applicable, reliable, and supportive studies, we used the guideline that pretty much led us to pick in the best resources. We had to distinguish between primary and secondary resources, identify strategies for locating relevant electronic resources efficiently, and for those, we, as previously mentioned, we mostly used Rutgers Library, PubMed, Medline, different biological search engines, as well as Google Scholar. And then we just pretty much made sure that everyone understood the differences between reliable and non-reliable electronic resources and discard the ones that did not meet the criteria. We limited our resource language to just English. We also limited the websites or the engines to a specific time frame, pretty much from 2021 and 5 years previous to that, nothing older. We also limited to only scholarly work to try to narrow down like so many numbers that we were getting for different searches. And then lastly, we made sure that if we used anything that was not from a scholarly article, that it was from a website. It had edu, like schools or university information, or the had.gov, which include like any governmental agencies. For a data collection process, once each member found their articles, we had to pretty much put them in a certain format so that we would all be able to understand, revise, and identify them. So each article had to have their headings and summing up the main topic that was covered, the source code, the author's name, and the abbreviated source's title. If they had a specific page number where they got their information from, we had to also have that, as well as the URL for the website to be able to find it and for all of us to go through it. All of this allowed everyone to review the work together and to choose the best 5 articles as well as their CPG. All of our work was processed via Google Docs. We created multiple documents to be able to work together. We had meetings to contribute in editing and adding, as well as synthesizing the data all at once so that we can all contribute. If not, everybody
For a data collection
had a part that they had to, once each member found their articles, we had to pretty much put them in a certain format so that we would all be able to understand, revise. So for our variables of selection regarding the PICO question, our independent variable was the implementation of resources for clean injecting supplies / sterile injections to drug users. This was supported by the safe injection facilities. It is known to reduce harm and social costs associated with drug injection, and these facilities are being implemented in places like in New York, where we were able to find data on that and how that has worked and helped decrease the rates of readmissions for IV drug users and the complications that come with it, as we mentioned in our PICO question, one of them being endocarditis. We also have used the IE and drug use disorders from the University of Virginia and their medical center. They had a lot of valuable contributed data for our independent variable regarding readmissions and the length of stay for these kind of patients. And for the dependent variable, pretty much being endocarditis, a complication from the use of unsanitized injecting supplies on drug users. Just some background, endocarditis occurs when germs, usually bacteria, enter your bloodstream, travel through your heart, and attach abnormal heart valves or damage heart tissue. And fungi or other germs may also cause endocarditis. So IV drug users are high risk because they will reuse syringes and injectables to, because it's just easier accessing them. And then the fact that they don't have access to be able to exchange these supplies puts them at risk for obtaining endocarditis and other infections and illnesses like HIV. So the purpose of this and the whole PICO question and implementing this evidence-based practice would be to just eliminate that and try to decrease these numbers and protect the patients as well as the healthcare staff and the cost that is associated with this. We use National Readmission Database for a lot of the information we obtained from the endocarditis side and the dependent variable.
Our levels of evidence range from 3 to 4, with studies such as systematic reviews, retrospective studies, non-experimental studies, metasynthesis, quantitative studies, and also a clinical practice guideline.
Infective endocarditis is one of the most severe complications of parenteral drug abuse. The incidence of infective endocarditis in IV drug users is about 2 to 5% per year, which is responsible for about 5 to 10% of the overall death rate. Complications of infective endocarditis include cardiac, metastatic, neurological, renal, musculoskeletal, pulmonary complications, and systemic infection. More than one complication can occur simultaneously. As drug use-associated infection endocarditis, hospitalizations and surgeries have increased throughout the years. How are these outcomes being addressed? Only about a quarter of intravenous drug use infective endocarditis patients are offered addiction consultations or psychiatry consultations for their drug habits. Intravenous drug use infective endocarditis rates are increasing and will likely continue to do so without any targeted interventions. As the incidence continues to rise nationally, given the increased readmission for endocarditis, septicemia, and drug abuse, infective endocarditis presents a serious challenge to current management of endocarditis and a disproportionate increase in deaths. What needs to be monitored with a fine-course lens is how effective are syringe exchange programs and how are they being promoted.
As with most studies, there were some limitations that we found in our research. Patients who had previously been treated for infective endocarditis who also died from overdose may alter the findings that were found. The death certificates also may lack accuracy in the cause of death attribution, which means infective endocarditis deaths due to opioids cannot be directly linked. There are limitations of the accuracy of the data and potential coding errors within the NRD database. The NRD does not provide detailed data on race, geographic region, or other demographics that could be valuable in pinpointing the changing demographics. The study was also limited by potential errors associated with coding, specifically the lack of an ICD code for IDU. The chart review process was done in part to account for those errors. There is also clinical information that may have been subject to inaccurate coding of drug use or other diagnoses. Infective endocarditis or drug use diagnoses could not be validated with other clinical indicators or assess surgical indications. Lastly, increasing awareness of both HCV and opioid misuse may have amplified their documentation during the later study years.
After reviewing the articles, we found that infective endocarditis rates are increasing and will likely continue to do so without interventions in place to help people who inject drugs. A study at a North Carolina hospital found that 11% of the admissions were drug use-associated infective endocarditis. 17% of the hospitalizations with surgery were for drug use-associated infective endocarditis. Expanding the accessibility to outpatient antibiotic therapy eligibility for people who inject drugs frequently may aid in offsetting the long hospital stays for drug use-associated infections. The incidence of injection drug-associated infective endocarditis continues to rise nationally. Given the increased readmission for endocarditis, septicemia, and drug abuse, injection drug-associated infective endocarditis presents a serious challenge to current management of infective endocarditis.
As we identified and summarized a policy that was drafted in September of 2016 by New York State Department of Health AIDS Institute, the policy states agency staff will develop referral linkage agreement with providers of health supportive services and substance use treatment programs so that syringe exchange program participants can receive required services. Our suggested recommendation for nursing practice based on analysis of the evidence we found as an increase in tracking intravenous drug use infective endocarditis in healthcare systems to serve as a warning sign for unsafe injection practices and potential risk for blood-borne viral outbreaks. Also, an increase in capacity of available maintenance therapy programs, abstinence therapy programs, and harm reduction strategies, as well as expanding outpatient parenteral antibiotic therapy eligibility for people who inject drugs, and expanding access to comprehensive health services and harm reduction services. And we can provide more resources and programs for needle exchange, programs that offer medical treatment for infection diseases, substance use disorders, treatment referrals for those without insurance or financial means, and community health programs and teachings to understanding IV drug abuse and how this practice can create safer environments for all drug users, including non-drug users. As we link the evidence to the clinical practice guidelines and the policy, safe injection facilities have shown promise in reducing harm and social costs associated with injection drug use. Safe injection drug facilities is a potentially useful public health intervention that should be available for evaluation and adaptation in the United States.
In conclusion, infective endocarditis has a high incidence of morbidity and mortality and continues to increase. The opiate epidemic continues to affect the United States population, and studies have provided ways to improve the care for patients with infective endocarditis. Delivery of comprehensive health services, harm reduction services, addiction treatment counseling, and safe injection facilities are some of the few services facilities can provide to help lower the incidence of readmission tied to persistent drug use. Future recommendations for research include focused studies on how the integration of addiction counseling during discharge planning can affect the rates of readmission for persistent drug use, evaluating specific safe injection facilities on how they can improve health of drug users without increasing drug use or crime, detailed studies on improving patient understanding of endocarditis related to drug use and how addiction treatment and harm reduction programs can improve health and decrease the risk of infective endocarditis.